Welcome to the We Talk Health podcast, the official podcast of West Tennessee Healthcare. I'm your host, Kara Mobley, and on today's episode, I have with me as my guest, Dr. Ted Wright. He is a cardiothoracic surgeon here with West Tennessee Healthcare through West Tennessee Medical Group. And today's topic, we're going to kind of be talking about the hybrid AFib therapy. Welcome to the show, Dr. Wright.
Thank you. Glad to be here.
So I know you did a podcast with us on AFib way back in 2020 with Emily Garner. So this
Correct.
Is your first interview with me on the show.
Right.
So that's been a little bit ago.
Yes.
And you were just recently in the news. WBBJ did a story on the Jackson-Madison County General Hospital offering this therapy to patients. And we kind of just want to give people a little bit more information on what is AFib, what is this new therapy. So I first want to kind of ask you about yourself. Give me kind of a background of how you got into cardiothoracic surgery. That's a tongue twister for me. And the work you've been doing.
Right. I joke. I've been in heart surgery since 2000. And after a long road of training, I joke and tell my patients I was in the 31st grade before I had my first job. But I've been doing heart surgery for a while. And one constant has been the surgical treatment of atrial fibrillation.
Yeah.
It's, I would say, a big part of what most heart surgeons do, but it has been a big part of our practice, my practice individually, as well as for our group. A lot of our patients come to the operating room with not just heart blockages or coronary artery disease or valve disease, but they also have atrial fibrillation. And our guidelines recommend and that we treat AFib at the same time in a concomitant fashion. So that's where a lot of our interests and clinical interests lie. But I've also treated for some time individuals who just have atrial fibrillation. Mm-hmm. The first successful treatments for AFib were actually surgical treatments.
Oh, okay.
But they were open operations that required being on a bypass machine and stopping the heart, and were quite complex. And for that reason, it wasn't really taken up by a lot of surgeons.
Oh, yeah.
But over time, we've learned a lot more about atrial fibrillation, how and why it occurs, and that's allowed us to create less invasive approaches that are more reproducible. And are theoretically safer for the patients and certainly effective.
And that's always good to talk about because anything in medicine, it's always evolving.
Yes.
New things are being found and less invasive treatments. Because sometimes when people think about certain things, they think about what happened long ago and they're like, oh, I don't want to get into all that. But medicine's constantly evolving and growing.
Absolutely right.
Now, in terms of cardiothoracic surgery, you've got cardiologists, cardiothoracic surgeons. Kind of tell me the difference or kind of what a cardiothoracic surgeon means.
Right. That's important for this conversation. So cardiologists, they deal with diseases of the heart and vascular system. They manage the medications primarily.
Okay.
And they can also intervene with catheters and stents. Stents for coronary artery disease, for blockages that could be opened with stents. They also can help with atrial fibrillation because they can do ablative therapies using catheters within the heart, inside the heart, to target areas of the heart that cause atrial fibrillation.
Yeah.
And that's important, particularly in the earliest stages of atrial fibrillation. When medications don't work and patients are still having symptoms, then they might deal with atrial fibrillation by targeting certain parts of the heart that cause AFib. Unfortunately, over time, if someone's been in atrial fibrillation for a long, long time, there are other areas of the heart that are responsible for atrial fibrillation, and those catheters aren't the most effective at getting at those areas. Fortunately, those other targets, these drivers of atrial fibrillation, are things that we as surgeons can get to pretty easily. It requires surgery to do so, but those areas that we can target to help minimize the amount of atrial fibrillation that patients are in, minimize their symptoms and minimize their other risk factors. And those, going back, those cardiologists that deal with the rhythm issues are called electrophysiologists. They're kind of the electricians of the heart.
Right, yeah.
And we work pretty closely with them in order to make sure that we can maintain normal sinus rhythm, which is a normal lub-dub that people feel every day. Going back to, surgical therapy, again, the first successful treatments were open surgical techniques. And again, as we've learned more and more about AFib and where it comes from, we're better able to target the areas of the heart that are important for a particular patient in their journey in AFib.
Yeah.
Again, folks who have been in atrial fibrillation for a short time, medications may work. Sometimes being shocked, cardioverted, can get them back into a normal rhythm. But over time, it could be that those things don't work, or people have toxicities or bad reactions to medications. Yeah. So other therapies need to be entertained.
Yeah. So would that be where the hybrid AFib therapy comes into play? And I know you mentioned that where AFib comes from. Right. Can people have it by itself, or sometimes, if you have something, another underlying condition, it can cause AFib? Kind of how does that?
Right. That actually all kind of comes together. So what can happen is that you can have triggering foci, as they call it, in the pulmonary veins that can trigger atrial fibrillation. And then when you're in AFib, it causes the heart to not contract as well as it should and could. And when that happens, you get decreased blood supply to the heart muscle itself, and you can get scarring that forms in the muscle in reaction to that. Other things like high blood pressure can cause the heart muscle to stretch. That stretching can cause scarring, and that scarring in itself can propagate or drive atrial fibrillation.
Yeah.
And that is where the surgical techniques that we talk about, that we use, are important, because they can help to target those drivers of atrial fibrillation.
Right. Now I know that I've got some key points. How many people have AFib? How prevalent is it? I don't know if you want to discuss, if you have any info on just generally in the U.S. or, kind of here in West Tennessee with what you do, with what we do here at the hospital.
Yeah, well, one of the reasons that we see so much atrial fibrillation here is because this is kind of the AFib belt. Why is that? Because if you were to look at a map and try to chart out where AFib exists, you'll see a lot of it in this area. But you'll also see that there's a lot of hypertension in this area. There's a lot of obesity in this area. There's a lot of diabetes in this area, which leads to sleep apnea in this area. And that all overlaps, because all those conditions can contribute to and propagate and cause atrial fibrillation.
Right.
And so then we go down the treatment pathway. Someone has AFib. In fact, we have a very, very busy emergency room here at Jackson General. And a lot of the people that they see are folks who are experiencing AFib for the first time.
Oh, okay,
They feel the palpitations. They may feel chest pains, shortness of breath. They get worried, and they go to the emergency room. And sure enough, they have new onset atrial fibrillation. In fact, it's estimated that 1 in 4 people over the age of 40 will develop AFib over their lifetime.
Wow.
So it's very, very, in fact, people call it kind of an epidemic. Again, it's an outgrowth of the lifestyles that we live and the results of that. Yeah. And so for that reason, a lot of times the folks that we see are folks who are well on their journey to atrial fibrillation. They have a lot more of that scarring that we talked about. And so for that subset of patients, more advanced therapies are necessary and are needed.
Right.
We have very effective surgical treatments, open surgical treatments. The Cox-Maze operation, which was developed specifically for atrial fibrillation, is very, very effective at getting rid of atrial fibrillation and allowing patients to get off of medications. Unfortunately, people are kind of reticent.
Yeah.
So people would rather live with AFib than live with the possibility or thought of enduring an operation.
Yeah.
Which is unfortunate, but understandable.
Yeah.
Now, fortunately, because of our greater understanding of atrial fibrillation these days, we're able to target those areas with less invasiveness, smaller incisions, without having to go in the bypass machine. It can require more than one procedure.
Okay.
In fact, in most instances, to be really good about it, it requires 2. It requires the electrophysiologist to. Let's start from the beginning. It starts from the surgeon working from the outside of the heart.
Okay.
To ablate the easily accessible areas on the outside of the heart that cause that drive atrial fibrillation in the posterior wall of the heart. And then following that, after several weeks, having diagnostic tests being done by electrophysiologists, and who can subsequently complete the ablations that need to be done on the inside of the heart, so that we're targeting the triggers of atrial fibrillation. Taken together, you can have very effective therapy that allows people to, in probably 90% of the time, to be without atrial fibrillation, to be able to put down the medications that they were taking for atrial fibrillation. And at the same time, what we do, there's an area of the heart called the left atrial appendage. It's important because in folks with atrial fibrillation, clots can form there, and those clots can create a stroke. And it can be big, devastating strokes. We actually get rid of that surgically during the procedure.
Oh, okay.
So that minimizes the risk of stroke and thereby minimizes the need, decreases the need for blood thinners.
Right.
Which is something that people are, that don't particularly like when it comes to.
Yeah. And like you mentioned, you were saying that you could have blockages and AFib and, that surgery can help. Yeah. Now, when you say minimally invasive and you talk about how people are kind of hesitant to get the surgery, kind of what's the turnaround time? What's the length kind of, is it, from compared to what it used to be to kind of what it is now?
Right.
To kind of help people, understand a little bit more about what it's like these days.
Sure. In contrast to open operative therapy, which requires going through the breastbone, requires stopping the heart.
Yeah.
In most instances, it usually requires a 3 to 4 day hospital stay as we try to sort out the rhythm and see how the patient's going to sort out from that standpoint, followed by probably 4 to 6 weeks of rehab, not inability to drive or do any heavy lifting until the incision heals. Contrast that to less invasive approaches. Using our approach here, surgery takes about 2-3 hours. Folks in general go home the next day.
Okay.
And we'll see them in a couple of weeks to get an ultrasound of their heart to make sure things look fine on the inside. And then 3 or 4 weeks later, they'll undergo the catheter ablation portion, the endocardial portion by the electrophysiologist. That typically is done in a couple of hours, and patients will go home the same day.
Okay. Now, when would patients come to you? Like, would someone recommend them to you, or how?
Oh, excellent question.
How do you see the patients when you're involved?
Yeah,
with
sure.
these
Excellent question.
treatments?
Well, what I've found is that there are a lot of folks with AFib, and they all have different journeys.
Yeah.
And so
it's different for everybody.
Right. And that's how it and that is a reflection of how they come to see me. I'll see patients who've had prior cardioversions, they've had multiple catheter ablations for atrial fibrillation, and still it persists.
Yeah.
And so they may be referred to me by an electrophysiology or by the general cardiologist to be considered for any kind of therapy for atrial fibrillation. Sometimes people self-refer because they hear about it, and they're a very savvy community. They're a sophisticated medical community. They communicate on blogs
and that's my big thing is
websites.
Advocate for yourself.
Exactly
is one
right.
of the big
and
things.
they are very good about finding out new sources and resources in order to be treated. And again, the other way that we find a lot of folks in atrial fibrillation is because they come to us with heart blockages or valve disease.
And you find it through that.
And we find it through that. They either present that way, or we go and delving into their history to see if there's any episodes of palpitations or any mention of AFib, because we know that if we treat those entities at the same time, folks do better over the long term.
Right. And I know you said you do follow-ups afterwards. Is there any other kind of post-operative treatment that you, or things that you tell people to kind of help them, stay away? If it's, I know you mentioned a little bit earlier, you could stay out of it, or would it come back? Kind of what are the post-operative outcomes?
So post-operative outcomes are good when you have a standardized program. And that entails a couple of things. One is having a dedicated surgical team. Yeah. The other is having a dedicated electrophysiology partner who's going to follow these patients. In the time after surgery, we have them on a medical regimen, beta blockade, whatever medications they were on for their AFib. In the short term, anti-inflammatory medications, because there is a lot of inflammation that occurs around the heart muscle. We want to minimize the risk of fluid around the heart that could hurt their breathing and stimulate the heart to cause recurrent atrial fibrillation. Yeah. And then after that, basically, once that's done and the patient's otherwise doing well, we send them for their endocardial procedure by the electrophysiologist. They can test the ablation that I did and add any additional ablations that might be necessary in a prescribed fashion in order to create what we call lesion set or scar tissue that is like and similar to what we would do with an open operation that we already know is very effective. Right. So we're trying to approximate what we do with open surgery through less invasive techniques.
Yeah, and again, you're tailoring it through a team for that individual person, which is great. Yeah, exactly. Now, I know you did kind of mention when people, present in the ER with some of these, and it does kind of sound like from this list I've got that I'm assuming maybe people think they're having a heart attack. Yes. Talk about kind of what the symptoms are of like early onset, or I guess, these are symptoms for early and advanced stages.
Chest pain, shortness of breath, decreased exercise tolerance, palpitations. Unfortunately, for some people, a stroke is the first symptom. Because they've been AFib and they can't tell, they can't feel it, and that's what happens. Right.
So who, and we've already kind of talked about this, but I'll kind of, as we're wrapping up here, who would benefit from this therapy for the people of West Tennessee?
I think that individuals who are in atrial fibrillation, who have failed medications or have not responded to catheter ablation, are certainly candidates to be considered.
Great. Yeah. And so obviously, talk to their doctor, I guess, if you're concerned or if you're thinking this might be something you need to look into. So, and this was saying if a patient has had treatment for AFib and the symptoms continue, that's when, you could consider the hybrid AFib therapy.
Absolutely. I think, there are a lot of folks who are walking around with a little bit of AFib, they say. But the truth of the matter is those folks live shorter, less happy lives.
Yeah, and obviously you don't want it to progress or worsen.
Exactly right. And so the more that the longer you're in AFib, the harder it is to treat, but it's not untreatable.
Right. And if you're one of the people that's listening that's maybe afraid, hesitant to do surgery, come talk to someone with the West Tennessee Medical Group. Maybe get in with Dr. Wright and see, what are your options?
Absolutely right. We got all the tools in the toolbox here, and that's the key. They can call the cardiologist at West Tennessee Medical Group. We have a cardiology group. They'll be happy to see and evaluate you and send you in the right direction.
Great. Yeah. And I will get that pulled up. I get that. So I'll have the phone numbers to call and the website on the show notes as well.
Sounds great.
So I know you mentioned the team of people that could work with someone to kind of get this
absolutely
treatment under control. And I know you mentioned an electrophysiologist.
Yes, yeah.
Kind of what is an electrophysiologist?
Right. The electrophysiologist is a physician who deals with the electrical system of the heart. If there's any disruption of the heart rhythm, that is the individual you go to. If you've ever heard of anyone who's had a pacemaker, chances are they have been seen and evaluated by an electrophysiologist. For instance, one of my clinical partners here is Dr. Simon Okawole. He's an electrophysiologist who works with patients with atrial fibrillation and does cardiac ablations. Okay. So he is my partner. So when he sends me patients or I refer patients to him. When I've done my epicardial portion, my minimally invasive portion of the procedure, after several weeks, I send it to Dr. Okawole for him to do the ablation from the inside of the heart.
Okay, yeah.
To create and complete the lesion set that approximates what we do in an open operation.
Right.
We currently, West Tennessee Medical Group, we'll be getting an electrophysiologist as well.
Okay.
She'll be arriving in the fall.
Okay.
And hopefully we hope to fold her into this program and integrate her into it. And so we can treat even more patients.
Yeah, and having those partnerships is great because, you work together and these are very highly specialized fields as well. So, I mean, each of these people, like you specifically with cardiothoracic surgery, these are very highly trained doctors who are working specifically for, their specialty.
Yes.
You're specialized in these particular treatments and disorders and things like that.
Exactly right.
Great, yeah. So, is there anything else you want to share? We'll definitely share the news article and we'll share all the cool things that Jackson General Hospital is doing.
Yeah.
And the surgeries that you've been able to.
Right. I would say that, we are fortunate. I am fortunate to have a wonderful, dedicated team that works hard to serve their communities all across the West Tennessee.
Yeah.
And without them, we couldn't do this stuff.
Right. Well, thank you so much for stopping by, Dr. Wright, and giving us some information on this topic that, it's a highly specialized field. And so getting just that information out there for people is good to have to help them advocate for themselves in any way.
And to know that it's not just, and to know that it's available here in Jackson.
Yes, right here in Jackson. All right. Thank you so much for coming by.
Thank you.
Thank you. Thank you for listening to We Talk Health. This podcast is not intended to replace any medical advice. Nothing said in this podcast is intended to supersede or supplement the direction of your medical caretakers. If you have any questions or would like to request a topic, you can reach out to us at wetalkhealthpodcast@gmail.com.